So talking about the different types of retainers, we know that we have a category of full coverage retainers and partial veneer crowns. So when you talk about a partial veneer crown, what does a full coverage mean? Full coverage means all the five surfaces are covered: the labial, the lingual, occlusal, mesial, and distal. So when you have all the surfaces which are covered, that is called as a full coverage crown. Right? The other type of retainer is a partial veneer crown, where when any one surface is not covered, right? We do not cover one surface. So the examples of a partial veneer crown is 3/4 crown. What do you mean by a 3/4 crown? The facial surface is left uncovered, right? You do not cover the facial surface. That is called as a 3/4 crown. Another important question from a 3/4 crown is that it is that crown which shows a wrench-like grip, right? This is the terminology which we use, which is called as a wrench-like grip. Now, in the 3/4 crown is usually used for maxillary canines, right? Why the labial surface is left? Because the labial surface is the aesthetic surface. We don't want to cover it up with the crown, with the porcelain. So that is how you use a partial veneer crown. Now, what is the major disadvantage of a partial veneer crown? The major disadvantage is that it is covering less surfaces. That is why it has decreased retention. To increase the retention, we have to add secondary retentive features, right? So you have to add secondary retentive features. That is the main disadvantage. The next one is called as a 4/5 crown. Now this 4/5 crown is usually used for premolars, where out of the five surfaces, just the labial surface is not covered. That is called as a 4/5 crown. Third variety is known as 7/8 crown, which is majorly used for a maxillary first molar. Why first molar? Because the mesiobuccal aspect is what can be seen in the smile of the patient. That is why the mesiobuccal is not covered in a 7/8 crown. The next component is a reverse 3/4 crown. A reverse 3/4 crown means it is that crown where the lingual surface is not covered. Where do I need this? I need this in my mandibular molars. Why? Because the mandibular molar has got a lingual tilt. To prepare that, you'll have to cut a huge amount of the surface. That is why you use a reverse 3/4 crown there. Next out of these is a mesial half crown. This mesial half crown, only the mesial and the lingual surfaces are used, right? And this mesial half crown are majorly used for your tipped molars, right? So there is no tooth preparation which is done on the distal or the facial, in fact distal and the facial surfaces, right? So these are the partial veneer crowns. Now in this partial veneer crowns, that is what you need to understand, that if this is my canine where I want to do a partial veneer crown, one surface is not being covered. That means I will have to add features for retention. So what do? I add a groove here, I add a distal groove here and a mesial groove, and I connect these grooves occlusally. So when I connect these grooves occlusally, this part is called as incisal or occlusal offset, right? So this is what is called as an offset used for your partial veneer crowns. Now talking about the full veneer crowns, right, which cover the entire tooth surface, the tooth preparation starts in the following order. First, you do the occlusal reduction, the labial reduction, lingual reduction, followed by your mesial and distal reduction. So you always start your tooth preparation with occlusal reduction, right? Now, what are the different types of full veneer crowns? You have a complete metal crown, you have an all ceramic crown, you have a metal ceramic crown. These are the ones which are most commonly used. How much reduction is required in which type of a crown? A lot of questions come on the values of it. So what I want you to understand here is that when you open your book called as Rosenstiel for fixed partial dentures, at the end of every chapter there is one chart, right? So you have that chart which will give you the details of what amount of reduction is required in what areas. Now, just to understand that, I'm not going to give you all the values. You can easily go back to your books and check that. But how do you understand that? Supposedly, this is my molar and I want to make a PFM crown. So for a PFM crown, I need to understand that 1.5 millimeter is the minimum reduction which is required. In this 1.5 millimeters, 0.3 mm would be my metal coping and 1.2 millimeters is going to be my ceramic layering, right? So that is the minimum metal coping what I require. But if I have to give an all metal crown, can I give it with a 0.3 mm coping? No. If you have to give an all metal crown, it has to be a reduction of 1 millimeter. Secondly, when you are talking about the cusps, if this is the buccal cusp, this is the lingual cusp, all the functional cusps must have a bevel. Why? Because this bevel is going to decrease the unsupported enamel rods. Another thing is this is going to increase the bulk of material present there, because the functional cusps are the ones which are going to take up maximum masticatory load. That is the reason you have a functional cusp bevel to be placed in maxilla or mandible, whichever molar you are dealing with. Always in the functional cusp, I require more reduction. So if 1.5 mm is the reduction done in the non-functional cusp, for a functional cusp, I would always require 1.8 to 2 millimeters of reduction. Right? So this is how you need to calculate what is the amount of reduction which you require. So once you're done with the preparation part of it, there is one another category which is called as RBFPD, which is the resin bonded fixed partial denture. In RBFPD, you have a Maryland bridge, you have your Virginia bridge, and you have your Rochette bridge. So Maryland, the question asked is what technique? It is an acid etch resin technique. For Virginia, you have a lost salt crystal technique. And in Rochette, you have mechanical perforations, and all these are cemented using resin cement. That is why they are called as resin bonded FPDs. The major problem with these FPDs is lack of retention, right? Because you are just using a little amount of the surface, relying more on the bonding capacity of the resin cement with the prosthesis when we talk about a resin bonded fixed partial denture. Another special kind of a prosthesis is called as Andrews bridge. Andrews bridge has two retainers with a bar, and that bar follows the curve of the ridge. That is called as an Andrews bridge. Another term commonly asked in questions is a Richmond crown, which has a lingual gold portion, right? That is what is called as a Richmond crown. Coming on to the next topic, after your tooth preparation, you get a lot of questions coming in from gingival retraction. Now, gingival retraction, the most commonly used method is retraction cords. Now, these cords, along with mechanical displacement, also require chemicals. What are the chemical methods of retraction? You have to use iron sulfate or aluminium chloride or adrenaline. What are these going to do? They are going to cause hemostasis in that area and contraction, right? So that is going to help in retraction, right? So this is how the retraction cords are used. How do you start inserting the cord? Which area first? Mesial, distal, labial, or lingual? Where do you first insert the cord? It is always the mesial end, because this area has an interdental papilla where you will have good amount of free gingival tissue, plus the mesial end is easily accessible. So once you place your retraction cord in that area, you can easily go around the entire area and place your retraction cord. So different sizes of retraction cords which are available for different areas, right? For molars you have thin cords, and then going ahead further you have thicker cords. That is how you place them. Another way is by using retraction pastes, right? So you have retraction pastes known as Expasil, or you have magic foam. So these are retraction pastes which have to be dispensed in the gingiva, and when you wash them after a couple of minutes, it is going to retract the entire gingiva in that area. Now there is something which is important and asked in questions, which is called as an every other tooth technique. This every other tooth technique is used for when you want to make a full mouth impression or a full arch impression. This technique is commonly used. Now, what is the material of this cord? This cord is made up of cotton, right? Why cotton is the base? Because this cotton is going to absorb the GCF and saliva, and it is going to expand, right? So when this cotton cord expands, it is going to push the tissue temporarily. That is called as gingival retraction. Now, when in some cases you have to use something which is called as a double cord technique. What is a double cord technique? A double cord technique is used when you have deep gingival sulcus. Because if you place one cord, that cord is going to go and sit in the deepest part, and the topmost part where you want to have the retraction, that area is going to close back. So in double cord technique, the most common question asked is, do you take a single cord and run it around the tooth 2 times, or you use 2 different cords? So the answer is 2 different cords, wherein the first cord must be made up of silk, not cotton. Why? Because you cannot place one cord inside which is going to keep on absorbing the liquid, but that is going to damage the entire tissue. Only the second cord or the top cord will be made up of cotton. Silk does not absorb any fluids, no liquids, so that is why you use the first cord which is made up of silk, right? So when is the retraction cord removed? What is the time required? 5 minutes is the time required for a retraction cord to retract that area and allow you to make an impression. Now, when you talk about impression making in FPD, it is very simple. You have already read a lot of techniques. The most commonly used materials are rubber base materials. So what we use is either a polyether, or you use addition or condensation silicones. These are most commonly used. So this impression making techniques, you have heard about a simultaneous technique and a putty wash technique. These are the most commonly used impression making techniques. In the simultaneous technique, the putty and light body are used together. So your assistant is going to load putty onto the tray, wherein you will be injecting light body around the tooth, and then you make your impression. The problem with the simultaneous technique is that this light body is a flowable material and putty is a heavily viscous material. As soon as you put your impression tray, the light body is going to totally spread out of that area. That is why we came up with another technique called as putty wash technique, in which once you load your putty onto the tray, you are going to put a cellophane sheet spacer and now make an impression. Once this impression is set, you take it out, you remove that spacer. That spacer is going to give you an accurate amount of space for your light body to flow. This is the best method of recording your impressions and margins. So when you use a putty wash technique, you have to make sure that your retraction cord should be present inside when you are making your impression with the putty, right? And the retraction cord must be removed just before you flow light body, right? So the retraction cord in putty wash technique has to be removed after the putty impression has been made, right? It has to be removed just before you inject your light body so that the tissue does not fall back onto the tooth. Another method is called as a triple tray method, also called as closed mouth technique. In this closed mouth technique, you have small sectional trays which are commonly used for single tooth, right? When you have to prepare a single tooth, record a single tooth. So you're going to use this small tray which has got a net-like structure in between. So you're going to inject your material on the top of the tray and on the bottom of the tray. Place it in the patient's mouth, ask the patient to bite. So that triple tray is going to record the upper teeth, they are going to record the lower teeth, as well as record the bite. So in a triple tray procedure, your one impression is recording maxillary impression, mandible impression, and the bite. All three are recorded. That is why it is called as a triple tray procedure. Do you use custom trays for FPDs? Yes. Why do I want to use custom trays for FPDs? Because in a custom tray, you can control the quantity of material. Why is that important? Quantity of material is important because all these polymers which you are using, right? You are using these rubber-based materials. All these rubber-based materials undergo something which is called as polymerization shrinkage, right? This polymerization shrinkage, more the material, more will be the polymerization shrinkage. Lesser the material, lesser would be the shrinkage. Lesser the shrinkage, higher the accuracy, right? So that is what we need to understand, that if you use less amount of material in a custom tray, the accuracy of an impression increases multifold. Now, how do you make this impression? You have to understand that latex gloves are not supposed to be used with rubber-based material. Why? Because latex gloves have got a component which is called as dithiocarbamate. This dithiocarbamate has got sulfur, and the sulfur inhibits the impression procedure, impression material setting, right? So never use that with the latex gloves, and you have to remember the component which interferes, known as the dithiocarbamate, right? Can alginate be used? Yes, we can use alginate. The only problem with alginate is its low tear resistance, and secondly, you cannot pour it multiple times, right? When you cannot pour it multiple times, if the impression has not been poured properly the first time, you will have to recall the patient, remake the impression. All those problems start when you have alginate impression. In alginate, you get a very common question about the chromatic alginate. What is the principle of chromatic alginate? You add water, it changes color. Once you mix it, it comes back to the same color. So the concept of a chromatic alginate is the change in the pH. As soon as you add unbound water, right, free water into the alginate, the pH decreases, the pH increases and comes near 7. That is why it changes color. As soon as the unbound water is completely bound with the alginate, the color goes back because the pH comes back to normal. So this is the concept of using a chromatic alginate. Now, once you do the impression procedure and send the model to the lab, the next clinical procedure involved is called as temporarization, also known as provisionalization or provisional restorations. Now, there are basically 3 different methods of giving a provisional restoration. The first one is called as a direct technique. Second one is an indirect technique. And the third one is called as an indirect direct technique. So what do you mean by these techniques? In direct technique, supposedly I am preparing a mandibular first molar to receive a crown. So what do I do? Before I start my tooth preparation, I'm going to make an alginate impression and store it in a Ziploc pouch. Once you are done with the tooth preparation, I will get the alginate impression, load it with my temporary material, either a tooth-colored self-cure or a bis-acryl composite. Once I load it with that material, I'm going to place it back in the patient's mouth. When I remove the material, I will have a temporary crown, exactly same as the original crown. Right? You can take it out, finish polish, and lute it with a temporary cement. What is the disadvantage of such a procedure? Supposedly, I'm doing a bridge. This is my 5 and this is 7. Now, if I'm preparing 5 and 7 and I want to give a direct temporary, will I be able to replace the pontic along with it? No. So if I cannot replace the pontic, I cannot give my patient the feel of a final prosthesis, what it is going to be. So this is one of the major drawbacks of a direct technique. What do you do in an indirect technique? You do your tooth preparation, make your impressions, and send it to the lab. The lab is going to fabricate a complete fixed partial denture, the complete bridge, including the retainer, the pontic, the connector, and next day you can lute it in the patient's mouth. Right? So this is called as an indirect technique. So indirect technique by far is the best way of doing it because you can do whatever changes you feel like. You can create the entire occlusion in this. You can give the patient the feel of a pontic present in the bridge, so that is how the final prosthesis can be done. The third technique is a combination of indirect as well as direct technique. These are majorly used in aesthetic zone. Now, if I have to do a tooth preparation for 6 anteriors and give a crown, so I will not be able to show the aesthetic changes if I'm doing a direct technique. If I'm doing an indirect technique, I will not be able to immediately give a provisional to the patient. These are anterior teeth and we need to give an immediate provisional. So what do? You record your impression prior to doing tooth preparation, use your BP blade handle and do tooth preparation on the model itself, right? Keep it slightly bigger than what you're going to do in the patient's mouth. Send this model to the lab and get a temporary unit prepared. Now this temporary unit will have the external surface form which is as per the aesthetic requirement. But when you try to seat it in the patient's mouth, you will have to reline it, right? So the tooth surface form or the TSF has to be relined with a new temporary material. So in this case, it is first the indirect part which has come from the lab, and then the direct part, the final fitting, which you do inside the patient's mouth. So this is what is called as an indirect direct technique, mainly used for the aesthetic zone areas. So the most commonly used material for temporalization is tooth colored acrylic resin. And nowadays what we commonly use is called as a bis-acryl composite. Now, this bis-acryl composite is a self-curing composite which is very fast setting, does not release any heat, right? And it can be used directly in the patient's mouth. So other than temporization, you get a lot of questions from shade selection. What kind of questions do we get for shade selection? How many seconds can you see a shade? 5 seconds, because after 5 seconds you have eye fatigue, right? What should be the neutral color, right? So you have gray as your neutral color. If you go around and see the entire spectrum of light, green is the central color, right? So green is also used as a neutral color. But gray is a combination of colors. It is not an original spectrum color. But gray is used a lot for your shade matching procedure. Other than this, what is the temperature of color? This question has been asked a couple of times. The temperature of color is 5500 Kelvin. Another important thing coming up from the topic of shade selection is the digital shade selection guides. So the digital shade selection guides have either colorimeters or they are digital color analyzers and spectrophotometers. So they work on different concepts, but the purpose of using all these is to have a digital shade selection, which is basically working on the reflected light. Whatever amount of light gets reflected, the color is evaluated from that. Luting agents, already we have you have discussed it in the dental materials part, but the important part here is what is the best luting agent available now? Resin cements, right? When they talk about best, which luting agent only has mechanical strength? Zinc phosphate. Mechanical plus chemical is your GIC, and when you have resin bonded GIC, so you have the in this cement the major advantage is that GIC sets by expansion and resins have shrinkage. That means when you use a resin bonded GIC, resin modified GIC, the advantage is that you are not going to have any expansion or shrinkage into that luting space. What is the amount of luting space required per wall? 25 microns is what is required for your GIC or zinc phosphate cements. The purpose of a luting agent is not a retention. The primary purpose of a luting agent is to prevent marginal leakage, right? That is the purpose of a cement. It is not that the cement is required to lute the prosthesis. The prosthesis should be retentive without a cement also. The purpose of a cement is only to prevent any kind of marginal leakage between the crown and the tooth and periodontium. Once this model goes into lab, you have a couple of questions which come from the lab part. How are the wax patterns made? They are made by using inlay wax. Why cannot we use a modeling wax here? Because inlay wax leaves no residue, right? There's absolutely no residue, almost 0.001% residue, that is all, right? That is the reason we use an inlay wax. They are of two types. Type 1 is a hard wax and type 2 is a soft wax, which is used for your indirect patterns, and the hard wax is used for your direct patterns, right? So this is what is important for us to understand here. All the dyes which are prepared, the question related to dyes is what system do you use for preparing dye? The most commonly used system is a Pindex system, right? All these dyes have to be hardened. So how do you harden the dye? You use something which is called as a dye hardener. What is the composition of a dye hardener? Cyanoacrylate is used as a dye hardener, right? Because the property of the dye, most important property of a dye is dimensional accuracy and wear resistance, right? I don't want my dyes to get worn off when I'm doing my wax pattern, I'm finishing my metal, I'm doing my ceramic, all those areas, I don't want any problem with my dye. So that is the reason you need to have a dye hardener which has to be applied before you make your pattern. Other than die hardener, there is something which is called as a die spacer, which is added because die spacer is going to give me space for the luting agent, right? So this is most of it what we are going to talk about. The fixed partial dentures, the important topics have been covered, but I would like you to go back and definitely read those charts from Rosenstiel, which will give you exact values which have to be replicated. You will have to reproduce those values when you are doing your when you're giving your exams, because those values, they always come up. Hi friends, so we are going to talk about removable partial dentures, and this session is going to be a short quick session which is the last minute revision points. So when you talk about removable partial dentures, there are a few things which are really important for us to know as far as the examination part is concerned. So we need to understand why we want to read removable partial dentures separately, because they work on a principle where the tooth as well as the tissue is involved. So it is tooth plus tissue supported partial denture. That means the biomechanics is going to be completely different. And when I say different biomechanics, what I mean is that the biomechanics of the tooth taking up the load and the tissue taking up the load is different, because the tooth is going to get displaced by less than 0.1 millimeters, whereas the tissue is going to get displaced by greater than 1 millimeter when we talk about functional loading. So that is what we need to understand, that there is a difference between the tooth and tissue. That is why we have to understand the biomechanics very carefully. Coming on to the basic part, the first level of questions which come in are from the Kennedy classification. When we talk about Kennedy classification, there are 4 classes and not 6. Do not make this mistake, right? What are the 4 classes? We very well know about it. The 5th and 6th are modifications which were made by Applegate, right? So we need to understand that when the question asks you how many classes of Kennedy classification, the answer is going to be 4 and not 6. The modification, other 2 are the modifications of Kennedy classification. And then Applegate gave you a set of rules, right? These rules govern the final classification, right? So that means it is going to give something which is called as modifications. So there are a set of 8 rules which you need to understand. The most important ones say that the most posterior edentulous space is going to determine the classification. That means when you talk about Kennedy class 4, there is going to be no modification involved in Kennedy class 4, right? Now, what an RPD consists of? A removable partial denture has got a lot of components which we are going to talk in brief, and starting with the first major component, which is called as major connector. What does a major connector do? A major connector connects one side of the arch to the other side. That is the function of a major connector, right? Now, these major connectors, the most important property of a major connector is rigidity, right? You will get an option of rigidity and comfort, aesthetics, retention. All those are not the primary properties of major connector. The primary most important property of a major connector is rigidity, right? Coming on to the maxillary major connectors, you have a lot of different maxillary major connectors. What are the very important questions which come up in maxillary major connector? What should be the distance between the border of connector to the free gingival margin? What should be that distance? The answer is 6 millimeters. This is the first important question coming up from maxillary major connectors. Now, what are the different types of maxillary major connector? We all know it. It is the first important one is the posterior palatal bar and the posterior palatal strap. Now, what is the difference? What are the indications? What are the contraindications? Which is going to be your first choice? Which is going to be your last choice? And what kind of cases? These are the type of questions which easily, most commonly pop up from the major connector section. So when you talk about the posterior palatal bar, the first important question is the shape, half oval. Very, very important for you to remember. Posterior palatal bar. Excuse me. So the posterior palatal bar is half oval in shape, right? Where do you use it? It is used in Kennedy class 3 cases. Kennedy class 3 means it is going to be a tooth supported RPD. So when you have a tooth supported RPD, you use a posterior palatal bar. It is half oval in shape. So that is what you need to remember. Posterior palatal strap is similar to the bar. It is just that the posterior palatal strap is more wide as compared to your palatal bar, right? Another important question from posterior palatal strap is called as L-beam effect, right? What do you mean by an L-beam effect? L-beam effect means that the bar is going to, if I talk about the maxilla, this is how the maxilla is. And if I have a posterior bar here, it is going to be located at this area, somewhere in the region of second premolar, not distal to it, right? And when you talk about a posterior palatal strap, it is going to cover up this entire area from the anterior to the posterior part. And here what you see is a sort of L, which is called as the L-beam effect. Now, when you have forces coming across this L-beam, a couple of forces will move into this dimension, the remaining ones will move into this dimension. So the force distribution is much better in a posterior palatal strap as compared to the posterior palatal bar. Coming on to the antero-posterior bar and antero-posterior strap, what are the major indications? Maxillary torus, right? If you have a maxillary torus right on the palatal, the antero-posterior bar or strap would be your choice. Talking about an antero-posterior strap, it is important that you have 20 by 15 millimeter space in between both the straps, the anterior and posterior, right? So it is important that you have this amount of space in between the anterior and posterior strap. Coming down to the next important type of connector, which is called as horseshoe shape. In horseshoe shape, you can have an open horseshoe or you can have a closed horseshoe. So how does a horseshoe major connector work? This is how you have a horseshoe major connector. Where do I use a horseshoe connector? When you have multiple anterior missing teeth, right? So when you have anterior missing teeth, you need a connector which is horseshoe shape, which is called as a horseshoe connector. Now, when you talk about an open connector, this area, if I add a posterior palatal bar here, this area is going to now become a closed connector, right? So when you talk about a closed connector, it is much more sturdy as compared, much more rigid as compared to the open horseshoe. The reason being, when you talk about an open horseshoe, this is how it is going to be. And whenever there are forces being applied, this is going to flex, right? So these flexion forces are the problem in an open horseshoe type of connector. That is why we prefer a closed horseshoe. If I want that this area should not bend, what am I supposed to do? I will have to increase the bulk of material, because if I don't increase the bulk of material here, the entire area is going to get flexed. Once you increase the bulk, what happens? It is going to become uncomfortable for the patient to be used because you have excess bulk in the maxillary anterior area, right? The next one which we have is called as a complete palate. So when you talk about a complete palate major connector, which is the complete arch, this is used when you have periodontally compromised teeth, right? So when you have periodontally compromised teeth, we use a complete palate, right? So it is not a very commonly used major connector, but this resembles your regular RPDs, which you make your RPDs in your graduation days. So you have those curvatures which you put around the teeth, something like this. So this is how you have a complete palate major connector, which is going to support all the other teeth. It is going to distribute load among all other teeth. That is why it is called as a complete palate major connector. Coming down to your mandibular major connectors, in the mandibular major connector, you have a lingual bar. Very important questions coming up from lingual bar is that you require 8 millimeter of space. Why do I require 8 millimeters? 3 millimeter from the gingival margin. This holds true for any mandibular major connector. 3 millimeters from gingival margin and 5 millimeters should be the width of the bar. That means from the free gingival margin till the floor of the mouth, what you require is at least 8 millimeters of space. So lingual bar is one of the most commonly used mandibular major connector. The next one is a linguoplate, also called as a lingual plate. Now this linguoplate or lingual plate is similar to the RPDs which you construct, which you make, making sure they're about their margins. So this linguoplate major connector has got two important points to be remembered. One is called as the ledging effect, and the other one is called as a step back technique. Now, what is meant by ledging effect and step back? Now, if you have a lingual plate covering onto the lingual areas, and there is a patient which has got spacing between the teeth. Now, if you have spacing between the teeth, it is sure that your lingual metal margin is going to be visible when the patient smiles. So those areas, what you are going to do is your major connector is going to come down and again down, so that when you have teeth present here and the space in this area, the connector goes down. When the connector goes down, you cannot see it. So this is what is called as a step back. Secondly, when you see the margins of your connector, they are going to lie on the teeth, right? They are going to lie on the anterior teeth. They have to be so thin that there is absolutely no ledging effect when we talk about the linguoplate major connector. Another important modification of a lingual plate is called as swing lock denture. Right? So the swing lock denture is a modification of lingual plate, which involves a labial bar with a small hinge. Right? This is what is called as a swing lock denture. The next one is called as a double lingual bar, which is also called as your Kennedy bar. Now, what is a Kennedy bar? A Kennedy bar is indicated only when you have open embrasures, right? So that you have support coming in because of the double lingual bar, right? What is the shape of? Whenever you talk about a lingual bar, right, the shape is always half pear shape. When we talked about the posterior palatal bar, the cross-sectional shape was half oval, right? So do not get confused when the question is asking you about a lingual bar or a posterior palatal bar. This is how the cross sections differ when we talk about these two bars. The last one is called as a labial bar, and this labial bar is usually used for lingually inclined teeth. Right? When you have lingually inclined teeth, you cannot put a lingual connector. There is where you have a major connector coming out from the labial side. That is called as a labial bar. The only disadvantage of a labial bar is aesthetics. Why aesthetics? Because this labial bar is going to distort the lower lip because it is present on the labial side. So that is what you need to understand, that this is going to distort the lower lip, and that is why we do not use a labial bar very commonly. So this is majorly about the major connectors. Next, we are going to talk about minor connectors, right? So in minor connectors, you do not get a lot of questions, but what you need to understand is the major function of a minor connector. The major function is to join all parts of the RPD to the major connector, right? So that is what is the function of a minor connector. So you will require a lot of different minor connectors in your removable partial dentures because they are going to join different parts to the major connector. Like the first one will join the clasp to the major connector. The second one joins the denture base to major connector. The third one joins indirect retainer to major connector. And the fourth one is again related to the clasp. It acts as an approach arm for infra-bulge clasps. Right? So this is what you need to understand, that a minor connector is going to basically connect the direct retainer to the major connector, the denture base to the major connector, the indirect retainer to the major connector. What kind of questions do appear from the chapter of minor connectors? The most important question, which is a very common question, is related to external and internal finish lines, right? So when we talk about a removable partial denture, which is like a distal extension removable partial denture, this is the situation. You have anterior teeth which are present, and these areas are going to be your saddle areas where I'm going to use my removable partial denture. So when you make a removable partial denture, just before the casting procedure, you have to place a small spacer in this area, right? And that spacer will have a small tissue stop, the way you do for your complete dentures, a wax spacer and a small tissue stop. So when you have, why do you have this wax spacer? This wax spacer is going to allow the acrylic to flow in between the meshwork, the acrylic to flow in between the entire saddle area, between the metal and the tissue. You're going to have acrylic. Obviously, for the area which is above the metal, you are also going to have acrylic because that acrylic is going to hold the teeth. So as I've already discussed the entire procedure of a cast partial denture in the full session. I'm not going to talk about it right now because that is beyond the scope of this session. But what you understand is that when you have the metal as a junction, acrylic on top of it and acrylic on the base of it. So the junction between this base acrylic with the metal is called as internal finish line, and the acrylic which is on the outer part, that junction with the metal is called as an external finish line, right? So that what I'm talking about here is the junction between the external acrylic to the metal and the internal acrylic to the metal, right? So that is what is called as an external and internal finish line. External finish line, the angle is always less than 90 degrees, right? Whereas the internal finish line is a butt joint. Very, very important part you must remember because this question has come up a number of times. The external finish line makes a junction which is less than 90 degrees, whereas an internal finish line makes a junction exactly at 90 degrees. That is why it is called as a butt joint. So how is an internal finish line formed? An internal finish line is formed as a result of the relief wax, right, which is placed before the casting procedure is done. Now, when you talk about the relation of the denture base to major connector, so you have seen cases where you have this as your removable partial denture, and these are the saddle areas. A few images you will see where you have the saddle area, which has got something like a ladder. A couple of cases where you will see thin ladder, and then you will see a complete meshwork, right? So you have different types of denture bases. So there are other denture bases where you have small beads which are going to hold the acrylic. Now, which area do I prefer to put a ladder? What area should I put just a bead or a nail head? Where I should have a mesh? Now, ladder and mesh, these areas are supposed to be used when you have both tooth and tissue support. Why? Because this tissue is going to get remodeled with time, with forces, and once this remodeling is done, I will have to reline or rebase my denture. So if I have to reline or rebase my denture, I require the acrylic to flow beneath the metal and above the tissue. Only then I will be able to reline. You cannot reline the metal. What I can reline is the acrylic part. So what you see here is that nail heads or beads are typically used in Kennedy class 3 or small span Kennedy class 4. But these mesh and ladder are used in Kennedy class 1 and class 2 because there is where you have a distal extension removable partial denture, and you will have to repeatedly do relining and rebasing with these dentures. Right, so this is majorly the important part from removable partial denture minor connector. These are the questions. So the bands which you see here are called as longitudinal struts, right? And the ones which you see other side are called as your transverse struts, right? So this is what you have to remember. The maximum extension for maxilla is going to be till tuberosity for the minor connector in the denture base, and for mandibular, the retromolar pad, right? So this is what is required. It should extend at least up to 2/3 of the ridge when you talk about the minor connector in maxilla or mandible. Coming on to the next important part, the rests and rest seats. Very simple concept, but a lot of questions coming up regularly from rests and rest seats. What is the primary function of a rest? Rests are part of removable partial denture, whereas the rest seats are part of the mouth. Rest seats are prepared on the tooth surface, occlusal, proximal, right? So these lingual, these are the rest seats. So rest seat is not a part of RPD. Rest, yes, it is a part of RPD. The main function of a rest is to direct all forces apically, right? Preferably in the direction of the long axis. So if you are getting the entire force directed towards the long axis, that is the purpose of having a rest. Now, what are the different types of rest? You have an occlusal rest, you have an incisal rest, and you have canine rests, also called as lingual rests, right? So we will talk about the questions which come up from occlusal rest, incisal, canine rest. So when you talk about occlusal rest, the first and the foremost important question which comes here is, what is the shape? The shape is always rounded, triangular when we talk about rests. Usually in options you might not get this rounded triangular, so if they have only triangular, you can pick triangular as your answer, but if they have an option of rounded triangular, that is going to be your first choice in that question. So the shape is rounded triangular. 1/3 to half of the mesiodistal diameter of the tooth and half of the buccolingual diameter of the tooth. This is going to be the dimensions of an occlusal rest. Angle, what angle does an occlusal rest makes with the margin of the tooth? It has to be less than 90 degrees. Supposedly this is the tooth and here is my rest. I make an obtuse angle. This obtuse angle will always lead to slippage. The prosthesis will keep on slipping. That is why the margin is always supposed to be an acute angle, right? The occlusal rest is always directed inwards. Inwards means it is going to be towards the center of the tooth, right? That is what is going to be the removable partial denture occlusal rest, right? Minimum thickness is 0.5 mm, but the thickness is 1 to 1.5 mm in the area where it crosses the marginal ridge, because you have a lot of forces in that area where you're crossing the marginal ridge. That is why you need to have more thickness. The next important question comes in from lingual rests. A lot of confusing questions is what is the shape of a lingual rest, right? Now, when you see a canine, these are usually made in maxillary canine. The questions usually asked are whether the shape is a half crescent shape, half moon shape, or is it a V shape. So we have to understand that when you see a cross-sectional view, in cross-sectional view, it is V-shaped. When you have a lingual view, it is crescent shaped or half moon shape, right? So it is very important to see what the question is asking. So if they are talking about lingual view, the answer is going to be half moon or crescent shaped. If they're talking about a cross-sectional view, the answer is going to be V-shaped, right? What are the dimensions? 2.5 millimeters mesiodistally, 2 millimeters buccolingually, and 1.5 millimeters should be the depth of the lingual rest. Coming on to the incisal rest, never the first choice. It is never first choice. Why? Because they are placed in the incisors, usually the mandibular incisors. If this is how the incisor is, V-shaped rest is placed. Now this should be around 1.5 to 2 millimeters away from the proximal incisal angle. Right? 1.5 to 2 millimeters away from the proximal incisal angle is this V-shaped rest. And it is going to be 3 to 3.5 millimeters wide and 1.5 to 2 millimeters deep. So if you have an option of giving an incisal rest or a lingual rest, we will always try and give a lingual rest. Why? Because the lingual rests are going to give more axial forces. Why? Because the lingual rests are placed very close to the rotational centers of the tooth. So if they are placed very close to the rotational center of the tooth, entire force is going to get transmitted along the long axis. And that is what is the function of a rest, as we discussed, that the rest is supposed to transfer forces apically. It is supposed to act as a positive vertical stop, does not allow your removable partial denture to keep on jumping. So rests are going to give support to the removable partial denture, right? And when we talk about the stability part, we discussed the major connectors and the minor connectors. So the third most important property of any prosthesis is retention. How do we get retention in a removable partial denture? So for that you have your direct retainers and indirect retainers. Right? So every component has its own function. So when we're talking about the support, we were talking about rests. When we talk stability, it is major connector, minor connector. When we talk about retention, it is going to be direct retainers and indirect retainers. Now direct retainers is a huge topic. There are a lot of questions which come up from direct retainers. So what you first need to understand is the major part of the classification of direct retainers. Now direct retainers can be intracoronal or extracoronal. Intracoronal are called as attachments, and these can be precision attachments and semi-precision attachments. When you talk about extracoronal, in extracoronal you can have attachments or you can have clasps. When we talk about extracoronal clasps, you have suprabulge and infrabulge clasp. In attachments, again, you have your precision attachments and semi-precision attachments. So we are going to talk about these clasps in greater details, but what we need to understand is what do you basically mean by the term clasp assembly. So when you talk about clasp assembly, the components which are involved here are rests. You have something which is called as a retentive arm, you have something which is called as a reciprocal arm, and you have a minor connector, right? So these retentive and reciprocal arms are really important because you have to understand that when the forces are being applied, the retentive and the reciprocal arm have got their specific purposes which have to be solved when you talk about a clasp assembly. So the retentive arm, terminal part of a retentive arm is always flexible. Which contacts first? A number of times this question has come, whether the retentive arm contacts the tooth first or the reciprocal arm contacts the tooth first. So it is always the reciprocal arm which is going to contact first, because the retentive arm is going to come in, get into the height of contour, and then engage the undercut area. So we do not want that the movement when the retentive arm is going in along the tooth, it should not push the tooth onto the other direction. So you have to have a reciprocal arm which is already present there to support the excess force which is coming up when you push the retentive arm in. So the reciprocal arm always contacts first, right? What are the requirements? Retention, stability, support. We know all these three. Three more important requirements are encirclement, passivity, and reciprocation, right? So we have talked about reciprocation just now. When you talk about encirclement, a clasp should at least cover 180 degrees. That should be the encirclement which is important. It should stay passive. the entire direct retainer, the clasp assembly, is supposed to stay passive till non-retentive forces are being applied, right? So that is what is important for you to see, that the entire prosthesis must be passive. What is the relation between the length of the clasp and flexibility? And so if the length is doubled, the clasp length is doubled, the flexibility increases by 5 times. Very important question. 5-fold increase in flexibility when the length is doubled. What is the optimum ratio of width is to thickness? 2:1. To get a good flexibility, at least 2:1 has to be the thickness, right? Prothero cone theory. A lot of times this question has been asked. Now, if I talk about a tooth, this is how a molar looks, right? So what Prothero said, that if I talk about this area, which is the height of contour, the maximum bulge present on the tooth, I can consider it to be 2 cones. Every tooth is considered as 2 cones, right? This area is going to be the height of contour. So the retentive arm should always be on the lower cone, and the reciprocal arm should be in this area, which we are going to talk about, so that as soon as the forces are being applied, the reciprocal arm acts and controls these forces in this area. Now, when we talk about different suprabulge clasps, you have already seen that there are a lot of questions coming up from suprabulge clasps, but we are not going to talk about all the concepts in detail here. But what is a suprabulge clasp, which comes from the occlusal part, right, which is called as the suprabulge. What is the bulge here? The bulge is the height of contour. So any clasp which is originating occlusal to the bulge is called as a suprabulge clasp, and any clasp which is originating inferior to the bulge is called as the infrabulge clasp. So how do you know these suprabulge clasps? Simple circlet. We have heard about this clasp so many times. The clasp which you make in your orthodontics, the C clasp, right? The C clasp of ortho, a clasp like this, is our simple circlet clasp. The prosthetic C clasp is completely different from the orthodontic C clasp. The orthodontic C clasp is our simple circlet clasp. What are the kind of questions? Which undercut does this engage? It is always the mesio-buccal undercut. Now you remember that if you have a case where you have your teeth present and this is the distal extension, your clasp will always come like this, right? The terminal of the clasp is going to engage this area, which means it is going to engage the mesio-buccal undercut of the abutment tooth, right? So simple circlet clasp will always engage the mesio-buccal undercut. Another important question is the cross section. It is always a half round cross section, and this is going to be our clasp of choice for Kennedy class 3, right, which is tooth supported RPD. So simple circlet clasp. Which undercut? Mesio-buccal. What shape? Half round. What is the indication? Tooth supported RPD. That is all what is required for you to learn about a simple circlet clasp. Similarly, you have a reverse circlet clasp. What is a reverse circlet clasp? A reverse circlet clasp is exactly the opposite of simple circlet. So which undercut does it engage? The disto-buccal undercut. Areas where you do not have a mesio-buccal undercut, those areas you use a reverse circlet clasp. Although there are other clasps also which can be used for a disto-buccal undercut, reverse circlet clasp, the major disadvantage is that it cannot be used in the areas of canines or premolars because it is going to be aesthetic failure, right? That is why we do not use reverse circlet clasp when you have a disto-buccal undercut. We move on to different options like infrabulge clasps, like C clasps. So we will be talking about that in a while. So these are majorly used for distal undercuts, the distofacial, distobuccal undercuts. That is what we need to remember. Third one is called as a multiple circlet. What is a multiple circlet? It is always used. The indication of a multiple circlet clasp is periodontally compromised teeth. It is used in periodontally compromised teeth. Where are these joined? You have so many circlets and they are joined, right? That is why it is called as a multiple circlet. So are they joined in the retentive arm or you have to join them in the reciprocal arm? All these clasps in multiple circlet are joined at the reciprocal arm. If they are joined at the retentive arm, it is going to be extremely high retentive force and you will not be able to dislodge the prosthesis when trying to remove it, right? It can become a kind of a fixed prosthesis. Next is your embrasure clasp. Now, where do I use an embrasure clasp? You have a situation like this, where you have all teeth present, and this is a situation of Kennedy class 2. You have this saddle area. This is one undercut which you have involved using your clasp, the mesio-buccal undercut. what undercut do I use on the other side? I don't have an undercut here to be used. So when I make my plate, I am going to cross over the occlusal embrasure and make sure that my clasp is on the embrasure and getting retention from both the teeth exactly opposite to the saddle area. Right? So this kind of clasp is known as embrasure clasp, indicated in Kennedy class 2. If you have a modification somewhere, you can obviously incorporate different clasps there. So in a Kennedy class 2 case, where you have the other side having all the teeth present, there is where we use an embrasure clasp. Ring clasp, we do not use a ring clasp much anymore. A ring clasp is indicated for tipped molar. Usually in the mandible, it is indicated for a tipped molar, right? And when you have a tipped molar, which is tipped mesially, you will usually have a mesiolingual line angle undercut. So if the question is talking about a mesiolingual line angle undercut in a molar, even if they have not used the term tipped, your answer is going to be a ring clasp. Coming on to the C clasp. Now the C clasp is also called as fish hook clasp or the hairpin clasp. The fish hook clasp or the hairpin clasp, what does it mean? Now you have a tooth like this, and if I give a clasp, right, what you see here is something like a hairpin bend or a fish hook. So in a C clasp, which is the fish hook or hairpin clasp, you have both the retentive as well as the reciprocal arm on the same surface of the tooth. Right? So that is what you need to remember, that this kind of a clasp will have both the retentive and reciprocal terminals on the same surface of the tooth. The only problem here is inadequate flexibility. Now in this case, which is going to first contact the tooth surface, the retentive arm or the reciprocal arm? Obviously the retentive arm. What we read earlier was that the reciprocal arm should be there first on the opposing side. But here, since we have placed both on one side, it is obviously the retentive arm which is going to first come in contact and then the reciprocal arm. The next important clasp is called as Rottweiler circumferential clasp, also called as combination clasp or a double bow clasp, right? Now what happens in this clasp, Rottweiler circumferential? So it is going to be a clasp where the retentive terminal is made with wrought wire. When would I require a wrought wire? When I have deeper undercuts. So when you have 0.010 inch undercut, you can use your cast clasps. And when the undercuts are more than that, like 0.015 to 0.020, in such cases you have to use a wrought wire, right? So you have a wrought wire clasp where the retentive terminal is made up of wrought wire. The other part is made up of the cast clasp. Right? So this helps in dissipation of forces, and that is what is called as a double bow clasp, or which is named as a combination clasp by Applegate. The next one here are the infra-bulge clasps. Now, infra-bulge clasps, they approach from the gingival side, right? And they give a type of retention which is called as push type of retention for the supra-bulge clasps and pull type of retention in the supra-bulge clasps. So what you need to understand that when you have an infra-bulge clasp, the infra-bulge will always give you a push type of retention, whereas the supra-bulge will always give you a pull type of retention because you have to pull the removable partial denture. So this is infra-bulge. Yeah. So what are the different types of infra-bulge clasp? So you have a T clasp, which is like this. You have a modified T clasp. You have a Y clasp, and you have an I bar, right? These are different bars. So when you talk about a modified T, when you talk about a T here, one is going to be your reciprocal arm, one is going to be your retentive arm, and this is going to be the approach arm, right? Which you remember that this is a part of your minor connector. In the modified T, the reciprocal arm is not there, so you just have a retentive arm. Y clasp is used when you have height of contour which is higher. So this is just a modification of the T. This was T and this is Y. It is just a modification. In I bar, which was given by Kratochvil, we have no retentive or reciprocal terminals which have been kept on the Y bar, I bar. So most commonly used infra-bulge retention is by the I bar, which we are going to read also the in the infra-bulge part. So next we are going to talk about the indirect retainers.